I really appreciate being here. I'm happy to talk about these issues. Been something on my mind for years now, but I think there's been a growing shift within the health professions, and many here today probably kind of see it and witness it as well. There's some data in this presentation today, but a lot of it is kind of an unknown in terms of what's going on in medicine and healthcare. And so it's not necessarily research heavy, it's maybe more concerns that I have and many colleagues I've spoken with have as well about the future of healthcare. Okay. So here's quickly the agenda. There's a couple or several different topics talking about today. Viewpoint diversity. I'll talk about a disconnect, and that's kind of the title of the presentation is practitioners versus their patients, this disconnect kind of alienating the public from healthcare providers. Censorship, patient-centered care, and cultural competence. And there's definitely some overlap between these concepts, I think. And you'll see that as I kind of talk through the points today. And that's okay, because I think they are all interrelated in terms of revealing this disconnect between the public and providers. So there's this shift. I kind of mentioned that at the very beginning, kind of teased it. The shift in the health professions. This isn't necessarily anything new within the health professions in terms of maybe a disconnect between the public and the providers. You know, you can think of it maybe white coat syndrome or distrust of physicians and medical providers. So especially in certain communities, it's been going around for a long time, probably a history of healthcare and medicine. But there's been a growing shift, I think, recently, and a lot of it is probably due to maybe political animosity and political polarization. So politics, I think, has kind of spearheaded a lot of the growing shift we're seeing. And so it's happening. It's maybe harder to gauge to what degree this is happening and its effect on healthcare. I'll bring up some kind of issues as we go through today, but just kind of want to lay that out first. And so what is this really leading to? And the shift in health professions, by the way, is similar to the shift we're seeing in academia in general. So it's a similar shift. So it's three things I can really think of: growing fear, increased echo chambers, and like I said many times already, this disconnect between patients and their providers. And so fear would be, you could think of it as students may be fearful in the classroom. You can think of it as academics fearful of pursuing certain research, whatever it might be. Maybe even a fear of mentoring clinicians. So this fear is really typified by self-censorship. And some censorship and self-censorship. Another thing is these echo chambers, which really is reduced consideration and appreciation of other views. If you just surround yourself with others who think like you. This is also a growing shift, I think, in health professions. There's more echo chambers. And then lastly, the disconnect. The data tends to show there is more public distrust in medicine. Some data show there isn't, but a lot of data shows there is, especially more recently within the past year. And a lot of that, of course, is maybe due to COVID as well. And then just strained relationships. Okay, so let's talk about viewpoint diversity. I know people on this presentation today probably have seen this many times and heard about it, of course, but just for the sake of it, I'll briefly review it. Viewpoint diversity, I like this definition: the state of a community or group in which members approach questions or problems from multiple perspectives. And so viewpoint diversity in context of faculty representation. Of course, it's not a direct correlation, right? So this is an ongoing argument, just because there's racial diversity doesn't necessarily mean there's viewpoint diversity. So they're correlated, but not necessarily, there's no causation to it necessarily. So this is a graph here. This is from Heterodox Academy, some data. Came out a couple years ago. They take faculty, this isn't just health professions, just all faculty in the US, a sample, and they graph and kind of plot whether they're overrepresented or underrepresented compared to the general population. But I do want to point out that this graph here on the right, it does mimic health professions as well. So the question we should ask ourselves is, what is the impact if there's maybe a lack of certain viewpoints of underrepresented groups within health education and health professions? And we got this red, I guess, rectangle kind of highlighting certain underrepresented groups on the right. Now in health professions, what's different than just general academia is that women tend to be a little overrepresented in health professions. But the other groups, especially Blacks and Hispanics, underrepresented racial minorities, are also underrepresented in health professions in terms of faculty representation. Christians, we don't necessarily have as much data about, so I'm not sure. I'm not confident about that. I would guess they are also underrepresented in health professions, academia. And then in terms of conservatives versus liberals, there is some data indicating, it's kind of the second bullet point on the bottom left. 2019 is, I think, the most recent data I could find. There are more physicians that identify as Democrat than Republican, and then there are more monies contributed to Democrats during federal elections. So I think suffice to say, I would feel comfortable in saying that physicians particularly tend to be Democrat leaning. Other health professions, such as myself, I'm a pharmacist, I would also tend to think it's Democrat leaning, but there's not as much data on that. So for decades, there's been a big push in healthcare and health professions to increase racial ethnic representation in healthcare. And there's a lot of reasons for that. Here are three ones most commonly, I'd say, represented when this argument's made. One is service patterns, secondly, race concordance, and thirdly, language concordance. And race concordance, language concordance, it's kind of the same concept, it's just according to race or language. So service patterns. Data shows over and over again, minority health professions are more likely than non-minorities to serve in underserved areas and serve underserved populations, including the poor and the uninsured. And so that's one of the big pushes behind why we would need more racial ethnic representation in healthcare professions. The other is race concordance, language concordance. And all these bullet points here, it's backed up by a particular study looking at, so basically if you share the race of a patient and a physician shares the same race or shares the same native language, it tends to lead to better care in certain areas and even better perception of care, and that the patient feels that they're getting better care from their provider. So these are the primary drivers behind racial ethnic representation. So the argument I would make, and I'm very interested in researching and finding more about, is maybe viewpoint representation. Increasing viewpoint diversity within health professions, what could that do? Particularly, I'm interested in political representation. So, because the data I just showed, thinking that, for instance, conservatives are underrepresented in health professions. So, for instance, could this affect the way providers provide treatment for their patients? The theory being a practitioner's viewpoint may influence their treatment decisions. There are some studies on this. From what I could tell, it seems to be mixed evidence. There was one study that found Democrat Republican physicians differ in how they would treat patients for politicized health issues, but it was a hypothetical scenario. So it didn't necessarily assess whether they actually did, but how they would do it in a situation. And there was another study pretty recent where they looked at end-of-life care between conservatives and liberal physicians, and they found no difference. And so that's why I said maybe there's some mixed evidence, but it's something to kind of think about. Another could be healthcare shortage areas. So I think many of us here are probably healthcare professionals. We've heard about these HCSAs, is the abbreviation or the acronym. Could one's political affiliation help explain why they may or may not choose to work and live in particular areas? And so when we think about healthcare shortage areas, we often think about underrepresented minorities. From the previous slide, they tend to a higher proportion of them tend to work in these shortage areas. But one shortage area that really consistently is not necessarily getting better is rural areas. And so my question would be, could the increase in Democrat physicians and healthcare providers, could that partly be attributing to the decreased want to go work and live in rural areas, which tend to be more conservative? And if you line that up with voting patterns and those types of demographics, it makes sense. and that people tend to surround themselves in communities that vote like them. And that's also backed by the radical change in landslide counties and federal elections. If you were to take a map of the US and color code it, red for Republican, blue for Democrat, you'll see there's been a drastic shift the past 50 years or so. And I think that could also be influencing healthcare shortage areas. Political concordance, so it's similar to race and language concordance. What about physicians or practitioners and their patients sharing the same political philosophies and ideas? Are some patients not receiving optimal care because they differ politically from their provider, especially if the provider maybe has a negative viewpoint of that patient's politics? Are some patients and communities not receiving best care because certain political beliefs are not represented among providers and policies in that community? And then to, I guess, further that point is public policy. When designing public policy, are all stakeholders involved? And one thing, this isn't all politics, it's just all types of stakeholders, but I'm particularly interested as of now in looking at maybe policies where there's only one, it's partisan, right? It's not a bipartisan policy. Does everyone have a seat at the table? Can one-sided policies work if it's designed solely by Republicans or Democrats? Are policymakers surrounded by echo chambers, right? So you never hear other viewpoints, and so maybe their policies are not as sound. And so this leads us to this disconnect. So there's a lot of data looking at trust in institutions in the United States. And this is all US-based data. This is from Pew Research Center in May 2020. The data, of course, is a little different now in 2021 as we kind of continue with the pandemic, and it's kind of changing all the time. This looks at trust in medical scientists and medical doctors. And so overall trust actually did go up in this one particular poll. But what I wanted to highlight is, and so you see the two kind of bars on the right, there's a group of bars for medical doctors and then for medical research scientists. I wanted to highlight the disparities here, the differences between groups. And so, the percent of US adults who say they have a mostly positive view of doctors and research scientists. If you notice, Blacks and Hispanics have lower positive view than whites. Younger people have lower positive views than older people. The less educated you are, you tend to have a lower positive view of medical doctors. And then Republicans tend to have lower positive view of doctors as well. And I'll come back to this, but I wanted to go ahead and kind of highlight this now because it has to deal with current trust in medicine, and I'll get to that in a second. So once again, just kind of highlighting here the disparities within groups when you stratify it by race, age, education, and politics. So what about trust in higher education? And I know we're talking about health professions today, but many of us in health professions, we're also academics, right? We work for schools of medicine, pharmacy, nursing, whatever it might be. And so unfortunately, this increasingly public distrust of our institutions is kind of a double whammy for us because there tends to be less trust in medicine and maybe healthcare, and less trust in academia. And so for a healthcare academic, it's kind of a double whammy, like I said. And so this was from 2012 to 2019. This is also Pew Research data. And they mapped, they split you by Republican and Democrats. Percent saying colleges and universities have a positive or negative effect on the way things are going in the country. And I wanted to particularly highlight, you notice the red boxes, Republicans in 2012, they actually, majority of them had a positive view of colleges and universities, and it's completely flipped. Now they have a majority have a negative view. Democrats have remained relatively stable. And so overall, among all adults, you'll see the views of higher education, its importance and its effect tends to be more negative over time. And I would argue if we looked at, right now, 2021, I think it's probably gotten even worse, although I don't necessarily have the data to back that up. And so this is where I wanted to kind of get back to those disparities. This is COVID vaccine hesitancy, or one way to kind of look at it. So we've got all these different subgroups, and the dark blue bar is those who already received at least one dose, And this was from May of 2021 from Kaiser Family Foundation. KFF is the source. And then the lighter blue is those who want to get vaccinated ASAP. The even lighter blue is those who will wait and see. The green, I guess teal green, is only if required. And then the darker green is they definitely don't want a vaccine. And so I'll put some kind of highlights here around certain groups which line up to overall trust of medicine and us as healthcare professionals. If you'll notice, Hispanic adults and Black adults, they actually have less vaccine, I guess, received at least one dose. A lower proportion of them have received at least one dose compared to white patients, Hispanics and Blacks. Adults without a college degree also tend to have lower vaccine utilization than those who do have a college degree. Republicans tend to have lower vaccine utilization, and those who are younger. And so this perfectly overlays on this previous kind of point, trust in medicine. So these are the real world ramifications of when there is public distrust of an institution. And I think we all kind of know this, but it's interesting to actually see some of the data behind it. And so less trust in medicine, less trust in academia, it affects things such as COVID vaccine hesitancy. Okay, another thing this can lead to in terms of maybe lack of viewpoint diversity is self-censorship. This data is from the Campus Expression Survey report, and most recent was 2020. You can access the report for free. It's housed at Heterodox Academy, and I have it in my reference slides, so definitely check that out. I think it's very interesting. They took a national representative sample of US students, and they asked them, what topics were they most reluctant to discuss? And what's interesting here, one is there's a lot of topics students were willing to discuss in class, but maybe more importantly, it seems to be getting worse. If you notice the light gray bars from 2019, the orange bars from 2020, and across every topic, it seems students are self-censoring more or more reluctant to discuss all these topics from 2019 to 2020. And from an academic standpoint, of course, we should be very concerned with this. We want students to really express themselves and seek truth in class and ask questions and learn. So if students are self-censoring out of fear, this isn't a good academic environment. And so the follow-up question is, for those who were fearful and did self-censor, why? What were the consequences you thought would happen if you did express your real views? And a majority of students, they said they were afraid that other students would criticize my views as offensive. And so it's not necessarily a fear of retaliation from professors, but maybe even just from their classmates. And you can see there's, I'm not going to go through all the other reasons here, but there's a lot of them, all of them alarming in their own way. And the reason why I briefly mentioned that is because this takes us to a recent, I guess, panel session. I moderated and also spoke a little bit, but you can see we have some of these other, speakers here, some of them involved with Heterodox Academy. This was a recent panel it was about a month ago at AACP, which is pharmacy's academic, main, I guess, academic body for pharmacy education. And it was a virtual conference. And we did a session on kind of exploring viewpoint diversity. And one of the questions, I asked 2 polling questions. We had over 100 participants, which was pretty good for that kind of session. And some of them maybe are not pharmacists, but this is among, I would say pharmacy faculty. Trying to see, what's going on in terms of self-censorship among health professions faculty, because there really is no data out there. I know we all have probably some stories, maybe we've personally experienced it, and there have been some highly publicized instances, but there's not really a lot of data. So this was kind of a peek into that. So and these questions are from the campus expression survey, which I just showed you some of the data with just general students. I asked some of the same questions to pharmacy faculty. So this first question, think about being at your school and teaching or discussing a controversial issue about gender, race, politics, religion, or sexual orientation. How comfortable or reluctant would you feel about speaking up and giving your views on the topic? And so about 40% said they were somewhat or very reluctant. So it's not a majority. And that's probably a good thing that a majority of pharmacy faculty from this sample did feel somewhat comfortable or very comfortable. But 40% is nothing, that's not, I guess, somewhat to be alarmed of. It's a big chunk, right? 40% are somewhat reluctant or reluctant to express their views. This next question, poll number 2, how often does your college or university encourage students to consider a wider variety of viewpoints and perspectives? And once again, this is from the Campus Expression Survey. This one was maybe a little more alarming. It's about, 61% of pharmacy faculty said only occasionally, rarely, or very rarely. And only 38% said frequently or very frequently. So it seems like at least colleges of pharmacy are less interested in exploring different viewpoints. And so I just thought it was interesting. I personally think if anybody wants to do more research with this, I'm very interested in pursuing some research with this, looking at censorship across health professions, because right now there's not much data on it. So censorship in healthcare, I kind of said this just a second ago, it's really difficult to assess the current kind of lay of the land and the direct effects. If you're censoring in the classroom, at a health profession's education, what are the long-term effects from that? How does that affect the health professional student, et cetera? We don't really know. There are, of course, specific instances, some of them highly publicized. I think many of us have spoken with colleagues or, like I said, personally kind of experienced some of this cancel culture and censorship. And there's also some recent articles. There's many articles, actually, more than I thought there would be, on maybe this shift that's going on in health professions. And these two in particular are pretty recent. And I would encourage you to check them out. I think they cover a lot of the context of what's going on in academia currently, or health professions academia. So now let's get to patient-centered care. So more ramifications maybe of a lack of viewpoint diversity in health professions. So patient-centered care, it's really intuitive to its name. It's to place the patient at the center of care. It's about a shared decision-making kind of model. So patients are included throughout the decision-making process. If you're interested in this, I would also highly encourage you to look at PCORI, a Patient-Centered Outcomes Research Institute, which has a lot of good resources, I think, on patient-centered outcomes and patient-centered research. But I digress. Anyways, each patient is different. What matters to one may not matter to another. So the idea is, once again, patients in the center. And so throughout the decision-making process, you're including them in on the decisions. Ideally, you're focusing on particular patient-centered outcomes, which would be more quality of life, functional status, such as ability to return to work, side effects and risks of treatment, symptoms, survival, and costs tend to be some of the outcomes patients most care about. So, for instance, a pharmacy perspective, something I commonly tell students, and it's kind of a common saying within pharmacy, is you could, spend an entire day in the clinic coming up with of course, with the help of other professions, coming up with the best treatment possible for a patient, the best maybe drug regimen. And you think this is going to be great. You have a whole monitoring plan, you got follow-up, you're ready to go. If the patient doesn't want to take it, they're not going to take it. It doesn't matter how well designed you made it. And so it's important to include the patient in the decision-making and that they're on board with your plan. So that's the kind of the premise behind patient-centered care. I don't know the full history. I wouldn't be an expert on this, but it's been around since I started in healthcare professions, and I imagine it's been around for decades. This kind of push in healthcare, and I think what's happening currently, and some of those articles I mentioned earlier, kind of highlight this as well, is maybe moving away from intellectual humility within health professions, which I think is critical for patient care. And so this is kind of the way, in my mind, I think of it, and I put it here on the slide. We should adopt the search for truth rather than activism. And so when I think of truth, I think about a journey. And so, research is a journey, right? You don't necessarily know the answer. You think you know, but you're open to being wrong, right? And so this truth, this kind of journey is really more dynamic. It could change, right? You're open to being wrong, you're displaying intellectual humility, and it's nuanced. It's really not dichotomous, it's not black and white. And so, for instance, I'll bring back that patient example. You have a whole drug regimen in mind, and then you talk with the patient, you figure out they have different priorities than you. Or for whatever reason, I don't know, religious preferences, they don't want to take that drug. You never know. You need to talk with that patient. You need to be open to changing your mind. In doing so, you can ultimately lead to better care. But the growing shift tends to be one of activism. That activism isn't necessarily inherently wrong at all. And there's a place for it. But activism is characterized by, someone who believes they already know the truth. They are already correct. And then they try to convince others or mandate change. And so it's typifies, tends to be more static, more closed-minded, and there's not as much nuance, tends to be more kind of black and white, right and wrong. And so the question is, are health professions promoting intellectual humility? And maybe what are the downstream effects from a focus on activism versus truth within health professions, education, and practice? And I think this is explaining some of what we're seeing now in health professions. Here's a patient-centered healthcare model. It kind of underscores what I've been talking about the past 5-10 minutes. Here's one particular model I like. You can see the reference down there in the bottom left is from Health Affairs Journal. It includes individual preferences, autonomy, and needs. And so there's different levels of healthcare. There's direct care. You can see the green box, green row at the top. There's organizational design and governance. So maybe you could think of even access to healthcare, and that's the red row. And then public health and policy making is that blue row at the bottom. And so the idea is you consistently want to include patients as you're, providing care, as you're, thinking about access to care, and as you're designing policy. You need the patient's input. It tends to lead to better policy because they will abide by that policy, right? Everybody has a voice. So, back to this question, do healthcare providers, do they do this? I would say increasingly no. Healthcare providers, especially for certain populations, such as maybe those who live more rural, conservatives, even you could say the poor, and still to an extent, definitely racial minorities are not included in these healthcare kind of processes, direct care, design and governance, and policy making. And this is underscored, for instance, I mentioned earlier, the vaccine hesitancy and what's going on, particularly here where I am in Alabama in the South. So here's another way of looking at it. It's the system versus the individual. And these concepts don't have to be in conflict with each other, but they are distinct in many ways. And so healthcare and health professions curriculum, and there's really no doubt about this. If you look at curriculum changes, you look at professional organizations, AMA, for medicine and pharmacy and nursing and all these different professional organizations, you'll see there is an increased focus on social determinants of health, systemic factors, and public health. But as practitioners, we're classically trained on the individual. So what's the ramifications if we focus more on population health versus the individual? And this is my opinion. I think it's really led to the loss of the individual. And so when we focus only on systemic determinants of health, we tend to negate the patient's experience, the patient's values, and the patient's choices. And ultimately, this leads, in my opinion, to an increased feeling of fatalism from patients, to where they have less control over their own health, and their health is determined from these outside factors. And once again, that's true to an extent. This isn't meant to negate these external factors to the individual, but if we focus solely on these external factors, then I think it can lead to fatalism with the patient, where they feel like they have no control, hopelessness, which has been shown to lead to worse health outcomes. There's this famous or I don't know, it's famous, but if you were to Google social determinants of health or determinants of health, this image will usually pop up. So you may have seen it before, but it's a nice kind of representation where it's got the individual kind of there at the center, and then you kind of broaden out to these different levels where it's more societal and general population health factors. Okay, another concept, cultural competence. So cultural competence, you may have also seen terms cultural humility, cultural sensitivity. They're very similar terms. There's maybe a bit of distinction. We're not going to necessarily get into that today, but they're similar terms. So I want to kind of mention that. So cultural competence, the definition, implies having the capacity to function effectively as an individual and an organization within the context of the beliefs, behaviors, and needs presented by consumers in their communities. So I like this definition of cultural competence because it's not that you appreciate and tolerate other cultures, but you are able to effectively interact and care for those other cultures. So it's not just you tolerate them, but your skill set, you are effective and you are a good provider for them, which I think is that next level and harder to do. And so, competency, humility, and sensitivity, they are being increasingly pushed in health professions education and practice. And for the most part, I would say rightfully so. I taught this at different pharmacy schools. My background is more in public health, so I'm a big proponent of it. The question is, and this is something I've kind of asked myself, why are health professionals surprised when people act the way they do? Particularly when I think of this question, I'm thinking about COVID. Or when certain policies don't work, such as vaccine rollouts. So for instance, I'll pick on Alabama for a little bit. We tend to have some of the lower, vaccine utilization rates. And there's a lot of healthcare professionals who are surprised by this. I'm surprised that they're surprised. I don't think they should be surprised. If they actually have a pretty good idea of, the quote unquote Southern culture and conservative culture in Alabama, I think that's what you would expect, actually, especially with current political polarization. And so people who are surprised when policies don't work or surprised when people act the way they do, I think it indicates a presence of echo chambers and that they really, there's a lack of viewpoint. They don't understand the viewpoint of this other side. And it indicates a severe lack of cultural competence, which is pretty interesting because there's so much focus on it within health professions education. So aspects of cultural competence, and this is one particular kind of training or model that I've used in my classes. I'll show you in a little bit why I chose this one today. So aspects of cultural competence, it really doesn't come naturally. It's more of a skill set. People aren't necessarily very good with overcoming differences at first. It takes practice. It's an ongoing process. It's not something you're ever perfect at. It takes time. You get better and better. To me, it's kind of like communication. It's just something you get better at. And then the idea being that the relationship between healthcare providers' level of cultural competence and their ability to provide culturally responsive healthcare services is this direct relationship. So the better your cultural competence, the better you provide care for different cultures. That's the idea. And it really consists of attitudes, knowledge, and skills that allow integration and translation of knowledge about various cultures into practice. And I underline their attitudes, knowledge, and skills. We'll go through that in a little bit. So the question is, are healthcare providers displaying appropriate attitudes, knowledge, and skills? So the concept here is to be culturally competent, you have to have the right attitude, you have to have the correct knowledge set, and you have to have the skills to be able to actually provide care for others. So as we kind of walk through attitudes, knowledge, and skills, just as a thought exercise, kind of think to yourself, do you think, your students or your colleagues or you yourself displaying appropriate attitudes and knowledge and skills to be culturally competent? So this is what this particular model says about attitudes. You need to have a positive attitude towards your own culture, as well as the cultural heritage of your patients. And so, for instance, if you were to think about politics, I think a lot of people fail on this, people and healthcare professionals. Maybe they don't have a positive attitude about the other culture. Some people don't have a positive attitude about themselves and their own culture. So if you fail at that, it's probably pretty difficult, according to this model, to be culturally competent. You must be aware of your own biases and values. I think a lot of people fail on that one. And I'm preaching a little bit here. It's me as well. Cultural desire. There should be a motivation to want to engage in the process of becoming culturally competent. So not mandating someone be culturally competent, but they should have the motivation to want to. And so I think a lot of people fail on this one as well, where they don't voluntarily seek out other cultures and try to change their attitude. Okay, what about knowledge? So this is about seeking other worldviews, explanatory models of disease, cultures, and health belief models. Culturally competent providers, they can understand how culture, values, health disparities, communication style differences, language proficiency, stereotyping can affect them personally and the patients and systems in which they work. This model recommends a great way to increase your knowledge to become more culturally competent is to these cultural encounters where you visit these other cultures. You become friends with people from other cultures. This can refine one's existing beliefs about a culture group. It can prevent stereotyping, and it can help lead to a better skill set because you gain more knowledge about that particular culture. Once again, the thought exercise here is, are people doing this? Are healthcare practitioners doing this anymore? I'm not saying it's ever been perfect, but with the current shift, I think we're getting worse at it. And then lastly, skills. And this is maybe the most important one. And that at the end of the day, can you provide effective care for someone different from yourself? And that's the ongoing challenge we have. So this is about having insight, patient assessment, communication skills necessary to work with a diverse population. So explaining an issue from other perspectives, reducing resistance and defensiveness in your patients, using appropriate verbal, nonverbal communication, acknowledging maybe you've made a mistake in the way you've interacted with people. Once again, if we kind of do the litmus test here, I think a lot of healthcare professionals fail at this, especially once again with political polarization. I included this here, and this kind of sums up cultural competence and patient-centered care. These are pharmacy, like accreditation outcomes. And I chose pharmacy here because I'm a pharmacist, but you could apply what we're about to do. You could also apply to medicine, nursing, any other healthcare profession, really. So these are, I'm looking at viewpoint diversity and kind of overlaying that with CAPE educational outcomes. Once again, these are for pharmacy, and these are used for accreditation purposes. So it's very important to healthcare professions. Education. And I underlined here, basically anywhere I saw viewpoint diversity is kind of integral to that particular outcome. So for instance, the patient's best interests are represented. You have mutual respect, understanding, and values to meet the patient care needs. You incorporate patients' cultural beliefs and practices, demonstrate empathy. I'm going down here, develop relationships, you value diverse opinions, promote teamwork, et cetera. And you can kind of read through all the underlying aspects. So the question is, are we really rising to this challenge? And here I'm speaking in terms of pharmacy. But once again, I think any profession would be interesting for them to really go through their accreditation standards and then overlay that with viewpoint diversity. And are they really doing what they need to do? And then here I also overlaid viewpoint diversity with the American Pharmacists Association Code of Ethics. Once again, I know every profession has their own codes, and so you could do the same exercise with your particular profession. So here I kind of underline different aspects of the Code of Ethics for pharmacists, where viewpoint diversity, cultural competence, patient-centered care is extremely important. And this is where my concern comes. I think health professions is moving away from this. So the question is, what now? So just as a quick summary, so you could tell, there's some data here, like I said, with the presentation, but a lot of this is somewhat uncharted territory, I believe, in health professions. And we have a lot of stories, we have some anecdotes. And so the question is, what do we do moving forward? And, I would say a lack of viewpoint diversity, really a lack of cultural competency for particular groups in the United States, lack of patient-centered care. All these things are kind of coming together, and they're related. There's definitely overlap, I think. And it's leading to increased fear, which is, self-censorship maybe, more echo chambers, and this disconnects between the public and the providers. And this, I believe, will lead to poorer healthcare and worsening disparities. I don't think this is going to help with any of those efforts. Okay, so the what now, what is needed? I think there's a lot of things. This is easier said than done. I think we need more viewpoint diversity within healthcare professions, education, and practice. So for instance, one example could be more bipartisan collaboration on policy making, I think would be helpful. And once again, the example I always think of is like vaccine rollouts. I think uptake in Alabama, for instance, would have been very different if there was maybe more bipartisan collaboration. Inclusion, so not just that there are different viewpoints, but those viewpoints are respected and heard and actually are incorporated. So inclusion, I think, is important. A renewed commitment to patient-centered care. So it's not that health professions should, stop talking about public health and these external factors, but I think focusing more on the individual would be helpful. We need a plan of action. And so this is where I'll make a shameless plug for our community health professions education at Heterodox Academy. We'll be doing some work soon enough to do more of that plan of action, what to do now, because many of us feel that this is a problem in our professions and in healthcare. And then lastly, and I bold and underline this, I think it's very important, is courageous leaders. Because there have been instances, and once again, many of us can, we know of them or we personally experience them, where there has been pushback on some of this shift, and then leadership has kind of caved in and not backed up maybe things they should probably stand for. And so I think courageous leaders, gatekeepers, if you will, is extremely important going forward. This cartoon on the right, I think, kind of embodies a lot of what I've talked about today. So I wanted to include it here. Health professions in many ways maybe is this kind of city on a hill. And if you're familiar with this, I believe it's a biblical, the idea being, or it stems from maybe a biblical perspective. But the idea being that we are a kind of a shining light. And I don't mean to have like a God complex or anything, but, people look to health professions, especially physicians. They look to them for guidance, for help, especially when things like COVID or we're in a pandemic. And so my fear is that you notice that flag at the top of the castle. If that's healthcare professions, we're very highly educated. We're usually pretty wealthy. We are, we could say maybe top 1% in status, however you want to define that. And there is this disconnect between us and the public. And once again, I mentioned earlier, I think there always has been for the most part. But I fear if we continue on this trajectory in health professions, lack of viewpoint diversity, lack of cultural competence, lack of patient-centered care, self-censorship, et cetera, I think this divide is just going to grow, and we're going to further alienate ourselves from the public, from our patients. And then how do we provide effective care for them if they don't trust us or if they view us as not representing themselves or their interests? It's going to be very, very difficult. And once again, we see this, for instance, with a lot of the COVID policy right now currently. And so I don't want to get there. And so the question is, can we correct course? And here's references. I highly encourage some of the Heterodox Academy references. I mentioned some of those articles I think are very interesting to read. And that's it for my presentation.